So today will be the last vocabulary that I'll go over with you. We finished up the traditional vocabulary terms last week, and all I have left now are these abbreviations that you would find in a medical chart or some common abbreviations you might see on a pharmacist or a doctor's pharmacy pad orders. And same idea as before. You can make note cards. What I'll do with this is I will give you a script, and it'll be handwritten out, and you'll have to tell me what each of the parts of that script mean, right? So it'll be pretty straightforward. I'll tell you about that again in a second. When you go to the doctor, they'll scribble something on a pad like this, and it'll say RX probably somewhere on there. The RX actually stands for a Latin word for the word recipe, and basically what the doctor's saying is, hey, dummy, take this, right? So this is your take instructions. And then after that will be the drug's name, the strength of the drug, and the quantity, the number of milliliters, or the number of tablets, or whatever it is that's being prescribed. And then you'll usually see SIG, S-I-G colon. And SIG comes from a word meaning write on the label. And the doctor is now going to put in, usually, code, what the pharmacist is going to write on the label in English words, instructions for you to how to take this medication. And after SIG, the instructions will include how much of the dose, how you should take it. Is it by mouth? Is it an IM injection in the muscle? Is it an IV injection into the vein? Is it something you would put in your ears or something like that if it's a drop? And then finally, how often should you take this particular medication? So those are the things that you're looking for written on the script. So here are some of those abbreviations. ATC. If I were to give you a medication and say, here, take this 3 times a day, when would you take it? The doctor says take it 3 times a day. Breakfast, lunch, and dinner. But some people might take it breakfast, dinner, and bedtime. Some people might take it, you can imagine that the variations would be rather significant. And some medications really do require that you take it at a regular interval. So if it's 3 times a day, ATC, that means it really should be at every 8-hour interval. And you shouldn't be messing around with, longer and shorter intervals. So some medications require that consistency. So the order might say ATC, meaning around the clock, or dose it at very regular intervals. BID, twice a day. C, or what's missing is a line over the C. C or C with a line over it is cum, meaning with. Cap is for capsule. CR, tomorrow. Dim, 1/2. So I just think of some of my relatives. They're kind of dim-witted. They're only half there. And then DX, diagnosis, right? So DX, you see a lot of terms with X at the end, and the DX is for diagnosis. GTT or GTTS is referring to drops or drop. HX, a history. IM, if you're injecting something IM, it's into the muscle. If you're injecting it into a vein, it's given IV. If you're going into surgery, or maybe you're going to have some tests done, you're told nothing by mouth. Perhaps not even water, maybe not even ice chips, depending upon what you're having done. NPO, nothing by mouth. OD, every day. OZ, ounce. Now, we use ounces every day in the kitchen. An ounce is also, 30 cc's. And cc is a cubic centimeter, which is the same as a milliliter. So these are just really common terms that you'll see, take 30 cc's, take 30 mils of this. And really that would also be equivalent to 2 tablespoons, capital T. 2 tablespoons is the same as 1 ounce. PC, after meals, other books would say with food. So just make sure you're not on an empty stomach, basically, right? So with meals or after food or with food, PC. PO, by mouth. So NPO is nothing by mouth. PO, you're going to take this medication by mouth, orally. PRN, as needed. Some of you may work PRN. You're only called in as needed, PRN. Q is each or every. QD, every day. QH, every hour. And QID, 4 times a day. So there the Q doesn't mean each or every. And some of these abbreviations are kind of going out of fashion, or even in some ways restricted in some hospital settings, because as you'll see here, QID is 4 times a day and QOD is every other day. And that could make a big difference if you misread that, right, or miswrote it. And so some of these now you'll see it actually written out 4x per day, right, 4 times a day rather than QID. But you'll still see some old docs still writing in these abbreviations. RO to rule out. So let's say a patient comes in and you suspect maybe they have diabetes, so you're going to do a blood sugar test to rule out diabetes. So you might put in a history, HX, history of frequent urination. Maybe they've got some diabetic issues. You're going to do a blood sugar test to rule out diabetes. And then if they did have a high sugar, you might come back and say the diagnosis, DX, was diabetes. S, or S with a line over it, sine, which means without. So C is with and S is without. Stat, do it immediately. T, 3 times. And again, this is where the T gets in a lot of trouble, because little t means teaspoon in some places, and or TSP, teaspoon. So that's why sometimes it's better just to write these things out. Remember that a teaspoon is only 5 cc's or 5 milliliters, versus a tablespoon, capital T, which is 3 times as much. So 3 teaspoons makes up 1 tablespoon. TID, there it is, 3 times a day. TX, treatment, and finally Z, more preferred for teaspoon. There's no doubt. Is it 3? Is it 3 times? Is it a teaspoon? Is it a tablespoon? Z, there's no confusion with that. So just simply what I'll do is I'll give you a script. It'll look something like this, and there'll be something written on here, and you'll have to tell me, what does BID mean? What does PRN mean? What does NPO mean? That kind of thing. And you'll just interpret it. You'll fill in the blanks, and that'll be just a little bit of a twist on the vocabulary that we've become accustomed to. So on the final exam, vocab will go, what was it, back to 93? Yeah. So urea on. Yeah, urea on to the very, very end, including the pharmacological and medical abbreviations. Any concerns about vocab? Do you think I should make it cumulative? In future semesters, should I make the vocab cumulative? What do you think? No? It kind of is in a way. We kind of build on it, but I've never specifically said, you know what, this is going to be a cumulative rolling over type thing. I've always kept it segmented, but every once in a while I'm tempted to see what happens if I made it cumulative and just throw out review questions every once in a while. We'll see. Maybe, maybe. Not this semester, right? Not this semester. Let's take a look. So when I see these chili beans, I'm sort of like, oh, I need some chili. Right? It's cold outside. But let's talk about the urinary system. Now, just like before, and as has been the case all semester, you've already seen the urinary system. Many of you are already geared up for an exam that includes the urinary system and the kidney structure. So this is not all going to be new. There's a lot of this is going to say, okay, I've seen this. Maybe I'm still mastering it if you have the exam Thursday night. Those who have the exam tonight, hopefully you're feeling really comfortable with the structures of the kidney. So listen in, and when it's reviewed, kind of kick back and say, okay, I've got this. And when I say something new, add it to what you understand about the urinary system. Now, the urinary system, we know that it's filtering our blood. Now, remember that when you're filtering the blood, what you're really filtering is the plasma, the liquid portion of the blood. And remember that the plasma is in constant exchange with lymph, right, with your interstitial fluid. So essentially, your kidneys are filtering both your blood and your lymphatic fluid, your lymph. And they're going to take these products that they filter and eventually modify those and create urine. And that urine will be sent from the kidneys down the ureters to the bladder and finally out the urethra. And I think we've got those structures just fine. Looking at a picture like this, pretty straightforward, I hope, and that we are going to see a couple of kidneys, right? And on top of the kidneys, we have the adrenal glands. We can clearly see the aorta and the inferior vena cava coming down from the kidneys, ureter, coming down to the bladder. This is a little girl. We see a uterus, a couple fallopian tubes, and some ovaries on this. And just as a quick review, remember we see this muscle back here, this muscle, psoas major. We saw that in our leg muscles. And then the muscle that fills up the ilium, the iliac crest area, that would be the iliacus. Remember that? And so the psoas major and the iliacus would sort of merge right about here to form what muscle? Remember the iliopsoas? Okay. So the ileoceles, just to review, nothing to stress you about. Now, if you were to open up your fetal pig or open you up, you wouldn't see this, would you? I mean, obviously the digestive organs have been removed, the liver, the stomach, all that's been removed, the pancreas has been removed. What you're seeing is everything behind the peritoneum. Remember that the kidneys and all of the urinary system are said to be retroperitoneal. And when you opened up your pig, you could see the kidneys back there once you moved all those digestive organs out of the way, but you had to poke through that layer of the peritoneum before you could literally touch the kidneys, and the layer that you were poking through was the peritoneum. Now here's an image you haven't seen before in lab, and that is looking at the kidneys from the rear. Now, yes, the kidneys are slightly protected. You have a little bit of bony protection from the floating ribs, but not as much as other critical organs in the body. And those floating ribs have an issue, don't they? If someone were to get hit at just the right angle with enough blunt force in the back, those little flat floating ribs could pop off and create some damage to the kidneys. So there is a fat layer, a couple fat layers around the kidneys helping to protect them from this rather precarious location. You can also note that the bladder is protected largely or somewhat by the coccyx. Again, if that coccyx were to get snapped, and some people's coccyx is a little more sharp than others, you can imagine that the bladder could be damaged by that projectile.
What is it when you feel like your ribs pop? What is that from? Like if you cough really hard or something? Okay.
My ribs don't pop. Anybody else's ribs pop?
Maybe like the intercostal muscles pop.
Yeah, intercostal muscles, but yeah. Yeah.
That's just what it feels like.
Feels like someone's hit you in the kidneys, huh? Okay. What else? I think that's about it on here. Notice the location. Remember that the ribs are coming off, right? Your floating ribs are coming off T12. So the kidneys are right about that T12 layer down to about L1 and L2, right? So they're in that region, T12, L1, L2, as far as anatomical location. Now, looking at an actual donor or cadaver image of this, you can see the couple kidneys, and you can clearly see the ureter coming down. This is an empty bladder. Doesn't look like much there, but that's the empty bladder. The rectum is here behind us, and this would fill up, obviously, and be a much more substantial organ if this was in a living individual. When you look at this, you can see the aorta, right? Aorta. And then these are the common iliac arteries, right? Right next to it, there's the inferior vena cava. And then you can see the common iliac veins. Can you see even in this picture a difference in the texture of the artery versus the vein? The aorta, right? Look at it again, clean it up. The aorta looks like if you pushed on that, it would kind of kick back at you. It looks round, it looks muscular, it looks strong. Whereas the vena cava next to it looks very flat, does it not? In fact, right here, that would be part of the common iliac vein. And it even looks flat from here, doesn't it? It looks kind of flat and not very muscular. So you can even appreciate artery versus vein just looking at the structures in an image like this. Okay, so a couple slides of information that you should be familiar with. That is the kidneys and the entire urinary system is considered retroperitoneal. That is, it's behind the peritoneum. The kidney has a hilum. The hilum is the area of the kidney where everything goes into or out of the kidney. So think the renal artery, the renal vein, and the ureter all coming in or leaving at that concave border of the kidney. Now the lung also has a hilum. The ovary has a hilum. Many organs have a hilum, an area where everything goes into or out of the organ, and the rest of the organ is pretty much nothing goes in or out of it. Now the kidneys, as you saw, are rather precariously located. There's not a lot of bony protection around them. So the kidneys are protected by really four things. Number one, the outer layer of the kidney is called the renal capsule, or the fibrous capsule. That's just dense connective tissue. There's a layer of fat around the kidneys. I'll show you a picture of this in a moment. That's the perinephric fat. Remember, nephro is one of those prefixes that means kidney, along with reno. So perinephric, we get that around the kidney. There's a layer of fat. Then there's the renal fascia. Now remember that fascia means a band or a bundle of tissue. So what you have is, I think of the renal fascia as being like a layer of saran wrap. And that layer of saran wrap is kind of holding the entire kidney and the ureter back against the abdominal wall. And then finally there is the perinephric fat. Around the kidney, yet another layer of fat. When you cut in the kidney, you see a cortex. We're used to seeing a cortex, that outer layer, and then the medulla, the inside, and within the medulla one finds pyramids. In your kidney, somewhere between 8 and 15 of these pyramids, and each of those pyramids has a point, and those points, or those apices, are all pointing toward the center of the kidney, toward the renal pelvis, and we know that it's in the cortex, in the medulla, where all those tubes are, all the nephrons, and the urine is being produced there and is all going toward the center. So if we look at this picture, now this picture has been stretched, no doubt about it. This is a very funky looking vertebra, right? But we can see spinous process, transverse process, and a big old weird shaped body of the vertebra. So it's definitely been stretched a little bit. And what you're seeing here are the two kidneys, and you notice that there's layers of fat around them. Again, you'll see two layers of fat, the peri and the perinephric fat. Over here we see the spleen, and over here the much larger kidney. Here's the pancreas in this area. So you can kind of get an idea of where you are within the body. Notice too that the kidneys are not directly across the street from each other. You'll notice that one kidney is a little bit more superior than the other along the aorta. And so when you look at the kidneys, you'll always see one is a little bit more elevated, if you will, and that is on the left side. So the left side is usually a little bit higher, and the way I remember it is the spleen's not as big. So the spleen doesn't, push it down as much as the liver. That's just the way I remember that. In the lab, we really didn't have time last week or 2 weeks ago to spend any time with the kidneys. And so we had them over there. We just never get around to cutting into them. And quite honestly, they're not the most exciting organ when you look in them. They don't kind of scream at you what's going on. It's really all microscopic. That's so cool about the kidney. But when you do cut into the kidney, what you can see, right, the fibrous capsule will be the outer layer. And then we know that that outer layer would be as you cut, you would see the cortex, and everything in the middle would be the medulla, and the medulla is broken up into these pyramids. Every pyramid is pointing toward the center of the kidney, and each of these pyramids is going to be draining into its own collection area called a minor calyx. So every pyramid has a minor calyx that's going to collect the urine produced in that region. And then multiple, so notice here's a couple, there's a minor calyx and another minor calyx, and those two minor areas are going to build up to make larger major calyces, plural, and then all the major calyces of the kidney are going to merge into a larger renal pelvis area. Now by the time the stuff gets to the calyces and into the renal pelvis, it's now urine. We're going to see that all the filtrate will be modified into urine in the tubes of the nephron, and by the time that fluid gets to this area of the kidney, it is urine, and all it's going to do now is go down the ureter to the bladder, get stored for a short while, and then released through the urethra. So here's a picture that I would have you label, something like this. So make sure you're familiar with this. And so again, we see here the pyramid, and notice that the pyramid is draining into its own collection vial, the minor calyx. And then up here you see 3 minor calyces, 1, 2, 3, all merging into a larger major calyx. The renal artery, the renal vein, and the ureter are all entering and exiting a portion of the kidney referred to as the hilum, and that's not labeled on this image. Just a little table, as I like to have: kidneys, ureters, bladder, and urethra. There's nothing extra on here. It just reminds you of these 4 major structures of the urinary system. Now, I didn't review the lab quizzes from your sections, but my lab sections, they did pretty well on the urinary and the respiratory quiz, but the area of greatest struggle was on that triple panel model of the urinary system. Remember that's the model upstairs that has the renal corpuscle, the glomerulus and the Bowman's capsule. The middle had a pyramid, and the far side had sort of a representation of the entire kidney cut open. And that seems to be the place where most of the struggle is coming from in the anatomy of this system. So let me go through this with you and get you to see this again, maybe in fresh eyes. We've got two things to keep track of in the kidney, and we have the anatomy. But now we've got two things of fluid to keep track of. The first is the blood flow. We know that the kidneys are filtering the blood. So blood must come into the kidneys through the renal artery, leave out the renal vein, and somewhere in the middle of all that, quote, we are filtering. So we got to keep track of that. The other thing we have to keep track of is that once the blood is filtered, that, quote, filtrate, that fluid is going to be traveling through a series of tubes, modified along the way, creating urine. So we've got to follow that story in a moment as well. But let's start off with blood flow. So we've got blood flow coming into the kidney, and here we see the renal artery. Blood is coming into the kidney. Now, it's a pretty big artery. There's a lot of blood going into your kidneys. Your kidneys are constantly 24/7 filtering your blood, and they must do so around the clock to get rid of the acids that are accumulating in your metabolism. Those acids are just a normal part of your metabolism, and we've got to get rid of them on a constant basis. So the blood's going to come into the kidney, and as all arteries do, it's going to split into smaller and smaller and smaller branches. We're going to skip over those intermediate names. I'm not going to worry about them, not holding you to them at all, but segmental, interlobar, arcuate, and interlobular, we're not going to worry about those names. We're going to pick up the story, though, at the microscopic afferent arteriole. We know what that word means. Afferent means coming in, right? The afferent neurons were the sensory neurons coming in to the central nervous system. And it's an arteriole, a small artery. So it's carrying oxygenated blood into a small vessel, the afferent arteriole. Now, the afferent arteriole is going to enter into a ball of capillaries. Remember the word glom? The prefix glom means ball. So it's going to enter into a ball of capillaries from the back of the room, right? This looks like a ball of red yarn. That's the glomerulus. And recall that the glomerulus is the place where the blood will be filtered. What is special about the capillaries here? What kind of capillaries are they? Fenestrated, right? That means they have the little openings, little holes in them. These are fenestrated capillaries, and the openings are not huge, but they're big enough for small waste products, these metabolic acids, water, glucose, ions, things like that are going to be small enough to get through these little openings. Then that blood is going to leave the glomerulus and exit through an efferent arteriole. This is where the kidney is unique to most of the body blood system, in that the blood is leaving out of the glomerulus as red. It's leaving out of this capillary bed as red, which tells us that what did not happen in the glomerulus? Oxygenation or oxygen exchange did not happen. There was no gas exchange in the glomerulus. All that happened there was filtration of the contents of the plasma. We come out into the efferent arteriole, meaning exiting, moving away from. And then, and this might be new for you, then that blood goes to a second capillary bed. Now there's two options here. A peritubular capillaries. The name tells us that the capillaries are going around the tubes. These are true, regular, continuous capillaries where gas exchange occurs. Or they go to a second capillary bed called the vasa recta. Now both those terms, peritubular capillaries and vasa recta, I know we're on your model inventory list in lab, but you probably didn't spend much time with them or really focus on what those things were, and I didn't talk about them in lab very much myself. Now, just to clarify, the peritubular capillaries, right, around the tubes are found right here. See all these capillaries going around the tubes here? Right? Those are the peritubular capillaries. Notice that those are going from red to blue. So those are normal capillaries. Gas exchanges happening in that capillary bed. And then the blood will leave out a series of veins, we won't name them, and eventually the blood leaves out the renal vein. Okay? So that's the basic flow of blood through the kidney. Now, the vasa recta I mentioned in passing, that is the other capillary bed that's a possibility. We know vas means vessel, recta means straight, right? The straight vessel. And what you'll find is that the vasa recta is this capillary bed that goes straight down along the loop of Henle, okay? But only in some nephrons. So it's a choice. Once the blood leaves the efferent arteriole, depending upon what kind of and the architecture of that nephron, it'll either go into the peritubular capillaries that we see up here or down the vasa recta, which is seen here. I'm not going to discuss the distinction of those two different types of nephrons until next semester, but we'll learn a lot more about the kidney, and we'll deal and dive into this into much greater detail next semester. So that's the blood flow, right? That's the blood going into and out of the kidney. Just to give you some numbers here, a fifth to a fourth, right? 20 to 25% of all of your blood, every time it comes down the aorta, is going to take a split and go to your kidneys. This is a massive filtering machine, 24/7. Lots and lots of blood going to your kidneys. Now, I don't have the number written here, but ladies, you are filtering every day about 150, I should take it back. You are creating 150 liters of filtrate every day. And guys, about 180 liters a day. We've only got 5 liters of blood. And we only have about 2.5 liters of plasma. And yet we are filtering that plasma over and over and over and over, such that our kidneys are filtering astronomical amounts of fluid. So clearly we can't let go of all that fluid. If we released all that fluid every day, we'd be dead, right, in just a matter of minutes. So we can't let all that fluid go out. As we've already said, the blood's going to come into the kidney, go to the glomerulus, right, that ball of capillaries that we've said were fenestrated, have the little openings in them. That's where the filtration's occurring. The blood's going to leave out an efferent arteriole. That was unique. And that blood is still oxygenated, right? It's red blood in, red blood out when it comes to a glomerulus. Hopefully that is all making sense to you. Now, I mentioned to you that there were two types. There was a second capillary bed, either peritubular or vasa recta. Let me just put that into words here and let you look back at this. Peritubular capillaries will be found primarily on nephrons that are in the cortex of the kidney, versus vasa recta, the other long capillary bed, the long straight capillary bed, will be going down deep into the medulla. Now, these capillaries are your normal capillaries. These are true, regular capillaries where gas exchange occurs and where nutrients are exchanged. Let me go back to the previous picture and just point out that again, now that I've shown you that slide. This nephron up here is a cortical nephron. It's in the cortex. There is only a very short loop of Henle that comes down. It's not very impressive. Most of the tubing is up in the cortex, so we call that a cortical nephron. And around the cortical nephron is where you find these peritubular capillaries. Versus this nephron, which we notice is deeper. It's down lower in the cortex. It's actually next to the medulla. That's why this is called a juxtamedullary nephron, next to the medulla. And notice that it has a much more impressive loop of Henle, and it's around that longer, more impressive, deeper loop of Henle that you find the vasa recta capillary bed. Okay, so again, we'll talk more about the physiology of the difference of those two things next semester. For now, we're just going through some terminology and some anatomy. Okay, so that's what I want you to appreciate about the blood flow. Now we've got to go back and deal with, once the blood is filtered, there is this, quote, filtrate made, right? 150 liters of filtrate in ladies, 180 liters of filtrate in men. buckets, right? That's a lot of fluid that is constantly being filtered. That filtrate, that fluid, is going to go through a series of tubes collectively called a nephron. And you have about 2.5 million of these nephrons between your two kidneys. Each of these nephrons is actually 4 parts. So we can dissect it into 4 parts. There's the renal corpuscle. You've seen it. That's the glomerulus with the Bowman's capsule around it. That's called the renal corpuscle. Then there's a series of tubes that comes off from that called the proximal convoluted tubule. Proximal meaning closer to the point of attachment. So it's attached to the Bowman's capsule. Convoluted meaning that it's very twisted. The nephron loop, also known as the loop of Henle, named after a dude who described it. And then finally, in another series of twisted tubes on the other end, on the distal end, called the DCT, or the distal convoluted tubule. Again, you have about 2.5 million of these collective units of tubes within the pair of your kidneys. And if you could stretch out this little set of tubing, each nephron would account for about 2 inches of tubing. That's pretty impressive when you think that you've got, 5 centimeters is 2 inches, right? You've got 5 million inches of tubing squeezed into the 2 kidneys. So if you take a cross-section through a kidney and you slap it on the microscope, what are you going to see? Tubes, tubes, tube, 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 right? It's 5 million inches of tubes microscopically squeezed down into the kidney. And you may remember back in histology lab, we showed you a circular arrangement of epithelium. Can you picture it right now? There was always that circular arrangement. And that circular arrangement we said was from the kidney. We didn't know what it was yet. We just said kidney. And it was the epithelium there was what? A simple cuboidal epithelium. And we always said, oh, the simple cuboidal's in the kidney. Well, that circular arrangement, it's a tube. It's one of these tubes that was going in and out of the picture that you saw in lab. Okay, so when you look at this under the microscope, and I'll show you a picture of that in a moment, you're going to be struck by the density of these tube-like structures. And then here's what I told you a moment ago, that nephrons come in 2 flavors, cortical and juxtamedullary. Cortical, up in the cortex, juxtamedullary, deeper next to the medulla, and the cortical nephrons had the peritubular capillaries, the juxtamedullary had the vasa recta. So let me just go through each of the 4 parts of the nephron. You want to think about structure, naming it, but also I'm going to tell you a specific thing that's happening in each of these areas of the nephron. So you want to kind of associate the area with its particular function. So the renal corpuscle, this is the very beginning of it. This is the glomerulus, the ball of capillaries, protected within that bulbous Bowman's capsule. Again, it's a dude's name. We're stuck with these names. And remember that the glomerulus has these leaky or fenestrated capillaries, right? Little openings in them. So in the last exam, we talked about arteries and veins and capillaries, and I think you're convinced that capillaries are rather delicate vessels. They are only composed of 1 layer, the tunica intima, which was simple squamous epithelia. There's not a lot of structure there, right? They're pretty delicate. They're awfully important, though, right? This is where all the gas exchange happens and where all the nutrient exchange happens. And now I'm telling you that this capillary bed, already delicate, has holes in it. So now, in my mind, I'm thinking lace, right? This is pretty delicate stuff with holes in it. To protect that integrity, that structural integrity, there are other cells that are going to come to the rescue here called podocytes. Cells with pods, cells with foot-like structures, right? Podiatrist. And these podocytes have these foot-like structures that are going to wrap around these capillaries and provide another layer of protection and structural support. They're also going to create these little filtration slits through which molecules must pass. So now we're looking at just a couple of the capillaries within a big ball of a glomerulus. We note that these capillaries each have little openings in them, right? Little small openings. Those are the fenestrations. And here's a podocyte. There's its nucleus. Has these big foot-like extensions that come around and wrap around the capillary. As they wrap around, though, they're creating another level with these little filtration slits. So that means that a molecule that's in your blood, that's being filtered out through the glomerulus, those molecules must be small enough and able to pass through the little fenestrations and the filtration slits. So really it's like a double layer of stuff through which the molecules must pass. Now the kinds of molecules that can get through these little openings, water, and lots of it. Small metabolic acids is stuff we're trying to get rid of. But glucose gets through this, really small. Sodium, all the ions can get through here. Small proteins can get through in limited amounts. But certainly nothing large should be showing up in your urine. Nothing as big as a blood cell should be showing up in your urine normally. These little fenestrations are really small. Now keep in mind, I didn't have you memorize the numbers, but a capillary is about 8 to 10 micrometers in diameter. And we know that a red blood cell is 7.5, right? That's one of the numbers we know. So that means that it's a pretty claustrophobic squeeze here, right? There's your red blood cell. And it's taking up the majority of the capillary's, diameter. So you would never expect to see a red blood cell getting through those little openings. Way too big. But if someone has a kidney infection, or has had trauma to the kidney, or has, after about 20 years of high blood pressure, there can be damage to the glomeruli. And as a result, the fenestrated capillaries can start looking more like the other kind of capillary. What were those? The big holes in them. Sinusoid or discontinuous. And at that point, now you could start seeing red blood cells and large proteins and everything else pretty much ending up in your urine. Trauma or infection to the kidney will usually resolve, and the kidney will start filtering again normally. So after you get punched in the back and you've got a kidney infection or damage to the kidneys, you might see blood in your urine as a result of the kidney letting some of the stuff leak through. But it will usually heal and resolve itself. If you've had high blood pressure for 20, 30 years, unresolved and not checked, what will happen is that the pressure going through the glomerulus will get, will be high over time. And these little fenestrations will start getting bigger and bigger and bigger. And eventually, you'll blow out the capillaries of the glomeruli, and now you will see blood cells and other proteins, large things, showing up in the urine. So when you go to the doctor and they do a urinalysis, they're always checking for a lot of things, but they're looking for protein. Is there protein in your urine? A little bit? Okay. But starting to see lots of it, there might be an issue going on here with some kidney damage, and certainly people with high blood pressure, hypertension, over time, will see more and more of this protein in their urine, and eventually even blood cells. And by the time you start seeing blood cells, your kidneys are pretty shot. And diabetes also destroys the kidney pretty nicely, unfortunately, and messes up the microvasculature of the kidney.
So is that why when you do a dipstick or a urinalysis, you see that they'll have glucose?
Glucose, now, we would not, and we'll talk more about this next semester, but in a normal individual, you wouldn't see glucose in the urine, right? We'll talk about this reabsorption process in a moment. Glucose that does get through the little holes will be reabsorbed into the body. We'll talk about that in a second. A diabetic has so much sugar in their blood that some of it, quote, spills over and shows up on the urine stick, right, in the urinalysis. And now we're diagnosing them with diabetes.
But will it be seen, I know when I used to nurse at BIOl, and I would do urinalysis on patients that came in, and it wasn't uncommon that they would have a UTI, but along with the red blood cells and their proteins would be glucose.
Right. Now, what's going on with that infection, with that UTI, the kidney was damaged, right, a little bit in that infective process. And so now it'll start leaking stuff through that it shouldn't, right? So you will see temporary, short-term blood, protein, who knows, everything else kind of floating through the kidney, right? But as it heals, it normally will resolve and go back to a normal urine sample. But a person after 20, 30 years of high blood pressure, it's not going to resolve, right? You're going to continue to have high protein and blood perhaps showing up in the urine. Okay. Make sense? Isn't this a beautiful picture over here on the right? I just think that this is just a beautiful image. The complexity, just the beautiful, it looks like lace, right? Some sort of lacy appearance of the podocyte with those little filtration slits wrapped around these delicate capillaries of the glomerulus. So this entire thing on the left is a renal corpuscle, right? So this is the renal corpuscle, and by definition, that is the glomerulus surrounded by the Bowman's capsule. We're taking a peek into it. It's been cut open for us to see this. Blood flow into each and every one of your glomeruli will come through the afferent arteriole. The blood will leave out of the glomerulus through the efferent arteriole. You can always tell the difference in the two. More blood goes into the glomerulus than what comes out, so the afferent arteriole will always be bigger in diameter. The efferent arteriole leaving will be smaller in diameter. So you can always tell in the model which one's which. Even in this picture, you can see those filtration slits along the glomeruli, and you can even see the little nuclei of the podocytes. Now, as this blood plasma is pushed through these little openings, fluid's going to collect. Okay, and it's going to collect in this space referred to as the capsular space or as the Bowman's space, and that fluid is filtrate. Right? And that's what you're creating 150 to 180 liters of every day. Huge. That filtrate is going to begin a journey going down this tube, and that is the beginning of the proximal convoluted tubule. Things won't flow backwards because of pressure. So there's always blood pressure pushing the blood into the glomeruli. So things are just going to push, through the glomeruli and down the proximal convoluted tubule. Under the microscope, what are we going to see? Tube, 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 tube. Just tubes, right, of these layers, and they're all going to be surrounded by the simple cuboidal epithelium. Then, this lollipop-looking thing, that's really referring to the Bowman's capsule. So the Bowman's capsule is the white kind of outline, and that means that everything inside of this would be a glomerulus, basically. So that's what you would see as you slice through a kidney. Tommy?
The distal convoluted tubule, I noticed is right in between the afferent and efferent. Is that?
Next semester. Next semester we'll
It's on the
discuss
model,
that.
right?
The model is absolutely correct.
The model has it right there.
It is always there, but not today. Okay? Not today. Not today. We've got so much more to talk about than that. Okay. So we're just going to get the basic idea of the anatomy here and try to figure out what the kidney's doing. So the proximal convoluted tubule, right? Once you've filtered the blood, that fluid is accumulating, starts going down the proximal convoluted tubule. You've got 2.5 million nephrons. That means you have 2.5 million afferent arterioles, 2.5 million efferent arterioles, 2.5 million proximal convoluted tubules, right? Going down. Now, the process that's happening here, and what I want you to think about, and the word I want you to see all over the place here is reabsorb and reabsorbed. Okay, so reabsorb, reabsorbed. I told you that you're making 150 to 180 liters of filtrate every day. You've only got 5 liters of blood and about 2.5 or 3 liters of plasma. That means that the body must retain, recapture, reabsorb the vast majority that is filtered through the glomerulus. We want to get back the amino acids. We want to get back the electrolytes. We want to get back the glucose. We want to get back the vast majority of the water. We only want enough water to continue through to wash away those waste products and create the urine, and we don't want to recollect the waste products. We want to get rid of the waste products and enough water to get it out of our body and pretty much capture everything back that's of use to our body's metabolism. So the process of capturing everything back is reabsorption, right? So something's being reabsorbed. Now, this is what I want you to appreciate. When we talk about reabsorption, those things that are, quote, reabsorbed are reabsorbed back into the peritubular capillaries. So for this, I've got to go back about 6 slides, back to that slide again, to make you appreciate what I mean by reabsorption into the peritubular capillaries. So here's our glomerulus. And here's the proximal convoluted tubule, right? And then notice that wrapped all around this, I can now see, right, these capillaries. I'm just going to put red there for now. So as the body is going to reabsorb this water and these nutrients back into the body, it's going to leave the tube and go back into the capillaries. Remember, capillaries are where exchange happens. So water exchange, nutrient exchange. So as the body recaptures this stuff, it's going to be recaptured in these peritubular capillaries that are wrapped around all these tubes. Okay, wrapped around the proximal convoluted tubule. We'll let that sink in here for a second. Then the filtrate, right? We've been capturing water back and glucose back and small proteins. Then the filtrate's going to head down the nephron loop, named after Henle, the loop of Henle. I'm not going to get into real fancy terminology here, but when that loop goes down deep into the medulla, it's kind of like what happens when you dive into the deep end of a swimming pool. The pressure increases. And as that filtrate goes down deep into the loop of Henle and comes back up, all I'm going to say to you is that the urine is being concentrated and changed and modified. And that's all I'm going to say about the loop of Henle. We'll get into that hideous story next semester. It's really interesting, but there's a lot more to it that we're not going to touch on this semester. Then, once you come up out of the loop of Henle, you're still modifying and changing the filtrate. This is not urine yet. Now we come up into the distal convoluted tubule, and there's two things that happen over here. Number one is a process of secretion. So I want you to circle that word. To me, it's a word that doesn't speak to me the way, when I think of secretion, I don't think of this process. Secretion is the opposite of reabsorption. So what does that mean? How would you describe reabsorption? Taking stuff from the tube and putting it back into the blood, right? Back into the body. So secretion is taking stuff from the blood and putting it directly into the tube, into what will become the urine. The molecule that I want you to think about, don't worry about potassium, I want you thinking about acid. What do you know about your urine? What's the pH of your urine? Basic or acidic? Acidic, right? Sometimes quite acidic. It can be 3, 4, 5, not uncommon at all. So that tells us, right, that our urine is acidic. There's a lot of acid in our urine. In fact, there's so many of these acids in our blood that the body needs a second process to get them into our urine. Not only are we going to let them filter through at the glomerulus, the acids, but we also need to have this process of secretion where we're going to put even more acid into the urine. So it's like a second way by which we get acids into the urine. So just think about this secretion, and it's the movement of hydrogen ions. Remember, hydrogen and acid and pH are all connected. The other thing that's happening in the distal convoluted tubule has to do with hormones. I'm going to cross off aldosterone. We're not going to talk about aldosterone this semester. But we are going to mention right now antidiuretic hormone. This hormone is abbreviated ADH. Diuresis is urination. A diuretic is a medication you take to make one urinate. So what would antidiuretic hormone do? Tell your body to retain water. So when you are dehydrated, your brain is going to kick out some ADH hormone. And the ADH is going to tell your kidneys, hey buddy, you're dehydrated. Now what happens to our urine output when we're dehydrated? It goes down, right? On a hot day or after exercise, your urine output will go down. And we all know that the urine in those moments is going to be more concentrated and darker in color. If instead you're well hydrated, then your urine output will be greater and the urine will be more dilute. It'll be more clear, right? Essentially water. So we all experience those differences based upon our hydration. That whole story is modified largely through hormones. And we'll talk a lot more about that story next semester, but that hormone, one of them is ADH. So I want you to know that hormone, ADH, antidiuretic hormone. So when you think about the distal convoluted tubule, two things should come to mind. One, the process of secretion, specifically of acid, and number two, ADH hormone control of fluid levels. Now, we're almost getting through the nephron. This looks like that second middle panel of that triple panel model that we have upstairs. And what we're looking at here, all right, we've got a pyramid over here basically. We're going to blow up the pyramid. Now this is still rather oversimplified, but this one shows two nephrons This nephron's way up in the cortex. So I'm going to draw a dotted line here. Above it is the cortex, below it is the medulla. So this nephron and that glomerulus and all the tubing is primarily up in the cortex. So that's a cortical nephron, and it has a very wimpy loop of Henle. What's missing here, what they did not draw here, is they did not show you the peritubular capillaries wrapped around the tubes. The other nephron on the left is deeper down by the medulla and has a much deeper loop of Henle. That's a juxtamedullary nephron. And what they did not show is that it would have the vasa recta wrapped around the loop of Henle. Okay, so that's what's missing from this particular image. Now, once the fluid has gone through, let me clear this. So let's try to follow this fluid. I'll put it in dark blue, okay? So we've just filtered the blood, and we're going to filter at the glomerulus, and we're going to start traveling through this convoluted tubule. Okay. What's happening during that proximal convoluted tubule? What process? Reabsorption, right? Then we're going to go down the loop of Henle, and I told you things are still being modified through the loop of Henle. Then we're going to come up into the distal convoluted tubule. What's happening in the DCT? Two things, the process of secretion and hormonal control, either to urinate more or urinate less. Then all of the nephrons are going to drop their fluid, filtrate, into collecting ducts. Now this picture only shows 2 collecting ducts. It's still very simplified, but there'll be multiple collecting ducts. All those collecting ducts are traveling downward, right? They're all moving toward the apex of the pyramid. At the apex, what would be right below that apex collecting that urine? The calyx, right? The minor calyx. One more term I want to include here, renal papilla. Renal papilla. Now we've seen that word papilla many times. We saw the papillary muscle inside the ventricle of the heart. We've seen the dermal papilla. We've seen the duodenal papilla in the digestive system. Now we're seeing a renal papilla. Papilla, remember, means nipple-shaped. So basically, I think of like little drip spouts dripping from the apex into the minor calyx. So the very tip of the pyramid is sometimes referred to as the renal papillae, or papilla. Now, if I could spend more time about histology. I love histology. I think you know that. I know Mr. Mueller loves histology, so you've gotten your fill of histology this semester. And you'll get more of it next. This is important stuff. But if we were to take a slice through a nephron or part of the kidney, we would see, right, that slice through a little bit of the what? What is this thing? That lollipop-looking thing is the renal corpuscle, right, the glomerulus. And then again, I would see tube, 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 just densely packed tubes. And all of those tubes would be lined by what kind of epithelium? Simple cuboidal, right? Filtration, simple cuboidal. Now, I can't tell the difference by looking at this histology at this level of magnification. But if I could zoom in really, really close, here's what I would notice. The proximal convoluted tubule, there's my simple cuboidal epithelium. It would have a lot of tall microvilli. Why do we have microvilli? To increase surface area. And what's the job of the proximal convoluted tubule? To reabsorb huge amounts of water and all of the nutrients that the body wants to regain. So to increase that ability to reabsorb all those nutrients, these cells are have a dense network of microvilli to increase the surface area. Versus, if I could, and I can't see it here, this is cartoonized, if you will, that's the word for us, right? It's idealized, but over here on the distal convoluted tubule, looks like Grandpa Joe's head, right? Not very many hairs up there. So we see very few microvilli, because what's the job of the distal convoluted tubule? It is not reabsorption, so we don't need as much microvilli. There, the job is secretion and hormone control. So we don't need to have the microvilli there. Does that make sense? Just to kind of If I could zoom in high enough into this magnification, remember you can't ever see microvilli anyway under a light microscope. So you would really never see this under light microscopy. You'd have to go to electron microscopy to see this, and I'm not going to hold you to that, but I want you to appreciate how the structure would be different between a proximal tubule and a distal tubule. So we've gone through the nephron. All we've got now to do is go through that collecting duct. And we saw the collecting duct going down toward the renal papilla and out at the apex. Well, this is the last chance for the body to recapture more water, also under hormonal control. So, if you are well hydrated, and we know this, if you are well hydrated, you're going to have more urine. No problem, right? Lots of urine output. But if you are dehydrated, you know that your body is going to tell you to conserve water. Your urine will be more concentrated and of less volume. We get that. And again, ADH is the hormone I just want you to think about that is being produced when you are dehydrated. It's telling your kidneys to hold on to the fluid. And that does not mean that the kidneys aren't filtering. The kidneys are still filtering 24/7, but they're going to capture more of the water, more concentrate the urine, and you'll have less output. But you're still getting rid of the waste products, right? They're just more concentrated. Okay, so again, the 4 parts of the nephron include corpuscle, PCT. You got the 4 parts. You've got the renal corpuscle, the proximal tubule, the nephron loop, and the distal convoluted tubule. Again, no facts in there that you need to know other than that I've already said to you. So that's the formation of urine, right? We'll talk more about this next semester. We'll break down what's in urine. We'll do a lab, and the last lab of the semester will be a urinalysis lab, and you'll test your own urine, and we'll test some, quote, pathological urines that are abnormal, and we'll talk about the kinds of things that your urine can tell you about your overall health. So that's all coming next semester with greater understanding of the kidney. We discussed the kidney a little bit in the parasympathetic and the sympathetic nervous system. We're talking about the autonomic nervous system. Recall that when the bear walks in the room, more blood is going to go to your skeletal muscle for you to run, fight or flight. Less blood will be going to your digestive and urinary systems. That doesn't mean it shuts off, right? You're not going to stop blood going to your kidneys. They're still going to be filtering, but more blood would be going to your skeletal muscles and less would be going to your kidney. And then when you're in that rest and digest parasympathetic nervous system mode, then more blood would be going to your kidneys. It should make sense to you that the nerves going to the kidney would collectively be called the renal plexus. We saw the cardiac plexus going to the heart. Remember, a plexus is a group of nerves. So all the nerves that travel to the kidney are collectively called the renal plexus. And those nerves are going to enter into the hilum of the kidney just like everything else goes into or out of the kidney. Now, we've made urine. By the time the filtrate gets to the collecting duct, and by the time, especially by the time that urine drips into the minor calyx, that is urine. The body has no other opportunity to modify, change, or anything. What drips into the minor calyx is urine. All it's got to do now is get out of the body. So it's going to travel down the ureter, go to the bladder, get stored, and then released through the urethra. So let's talk about those structures. So the urinary tract, right, would be with the ureters, about 25 centimeters long, about 10 inches in an average person. Mine are probably more like 12 inches, right? A little taller person would have longer ureters, but somewhere in that 10 to 12 inch range, maybe a little bit shorter if you're a shorter person. And we can picture that the ureters are going to start at the renal pelvis. Are you with me? Right, up at the renal pelvis, and they're going to go all the way down until they dump into the bladder itself. Remember that the ureter is itself retroperitoneal. It's also behind the peritoneum, just like the kidneys are. And the urinary tract is composed of 3 layers. These layers sound really familiar. We talked about layers of the small intestine. Remember the mucosa, submucosa, muscularis, serosa. Those 4 terms hopefully are rolling off your tongue a little bit. Those 4 layers of the small intestine. Well, in the ureter, there are 3 layers, 3 tunics. We know that term tunic means layer. And those 3 layers are the mucosa, the muscularis, and the adventitia. Now, I want you to appreciate why it's called the adventitia and not the serosa. How is the ureter different from the small intestine? Let me phrase it another way. Why do we call the outer layer of the small intestine the serosa? What is the outer layer of your intestines? Visceral peritoneum, right? That layer shrink-wrapped on your internal organs of your gut is a serous membrane, so we call it the serosa. The ureters and the bladder are retroperitoneal. They are not surrounded by a serous membrane. So to call the outer layer a serosa would be a great disservice, right? So we had to make up another name. So rather than serosa, right, we're going to call it the adventitia. We're on an adventure, we're outside the norm. That's how I remember it, right? Adventitia looks like adventure. We're on an adventure, we're outside of the peritoneum. The adventitia wraps around those structures. Now, if you took a slice through the ureter, it looks a lot like, at first glance, the small intestine. It really is. And I wouldn't ask you to differentiate, is this small intestine or is that ureter? But I do want you to realize 3 layers, right? And you can see them nicely in this cartoon. The inner layer is the mucosa. Do you agree that this is a mucous membrane? A mucous membrane is anything that has an access to the outside world. So clearly the urinary tract is mucus lined. So this is a mucous membrane surrounded by a nice layer of smooth muscle, and then on the outside the adventitia. Going down to the bladder is an expandable organ. We get that. In the female, it's directly connected or right below the uterus. We've seen pictures of that with the reproductive systems. And then in the male, we've seen the prostate gland in close proximity to the bladder. And remember that the bladder is also retroperitoneal. An empty bladder is kind of an upside-down pyramid, and as the bladder fills with urine, it becomes more oval in shape. Now, inside the bladder, there is an imaginary triangle referred to as the trigone. And I'll show this to you in a moment. And the trigone really is where the 2 ureters dump into the bladder, and then the other point of that triangle is where the urethra opens up. So it's the 2 ureters and the urethra creating a triangle called the trigone. And basically the bladder is like a filter. It's like not a filter, sorry, like a funnel. It's kind of like a funnel. When you think about it in a different way, you've got this large volume that's all moving down toward a very narrow urethra. So it's kind of a funnel-shaped structure. And the bladder has not 3, but instead 4 layers. It has the, let me go back, it has the mucosa, submucosa. We didn't have that in the bladder. Sorry, we didn't have that in the ureter. A muscularis, and once again, the adventitia. So we've seen this picture of one like it before. So this is just the bladder. Ureters coming down, left and right. This is the peritoneum. So again, the bladder is really not so much behind the peritoneum as it is below the peritoneum. It's below your gut organs, but we still say that it's retroperitoneal. Here's that trigone. 1, 2, 3 openings. So there's your imaginary triangle, the trigone. And now you can appreciate that funnel shape. What muscle's right here in this area? It's labeled. That's the internal urethral sphincter. And that is smooth muscle. That is involuntary. That's as the bladder is filling, it starts to push down on that internal sphincter and gives you the urge to go. This is an involuntary smooth muscle. Then, down here, there's a band of muscle. That band of muscle is called the urogenital diaphragm, and in that is a second sphincter that wraps around the urethra. That is the external sphincter. It is voluntary skeletal muscle. That's your toilet training muscle over which we hopefully have control. Now the muscle layer of the bladder, that muscle has a name, the detrusor muscle. And we had the word detruse in our vocabulary way back in the D world. And detruse meant what? I think that's what I had. Push away. Right? Detruse meant to push away. So as you are urinating, you are, quote, squeezing the detrusor muscle, and that is helping you to empty your bladder. So to push away or to void is squeezing of the detrusor muscle. There's one additional factor I want you to know about the bladder, and that is that it is lined by a different type of epithelium. I mentioned it in passing back in histology lab, and certainly during the histology lecture. You don't have to recognize it, but I want you to know that the bladder and the ureter are lined by transitional epithelium. It has a different look to it. Don't worry about memorizing the look to it. But it can transition. When the bladder is full, that outer layer gets very thin, like a simple epithelium. And as the bladder empties, that layer kind of jumbles up like a punching bag or like a deflated balloon. And it goes back and forth. It flexes. And so we call this a transitional epithelium because it can really change its appearance depending upon the fullness of the bladder. Urination is also referred to as micturition or the micturition reflex. So as you are urinating, that's micturition. This is a complex event. So as your bladder is filling, we have control over it, right? I mean, we like to think we have control over urination. Just like we like to think we have control over breathing. We can all sit here and hold our breath. But at some point, the brain says, hey, dummy, breathe. The same thing is true with the bladder. We have control over it. As our bladder is filling, we have control. We can say, not now, not now, not now. But there comes a point where we're dancing around the room, and then there becomes a point where we can no longer control it. So basically, a reflex kicks in, right? Something that we don't have control over kicks in. So when the bladder gets really full and we can no longer control it, then, quote, the reflex will take over and we will, right, undergo a urination accident, if you will. So what's going to happen then is that both ureters, both of the sphincters will open, the internal sphincter and the external sphincter. Out of a reflex, the detrusor muscle will squeeze out of reflex. It's smooth muscle. We don't have control really over the detrusor muscle. But as we relax the external sphincter and we allow flow, the brain and the spinal cord, as part of this reflex, squeeze that detrusor muscle. And this is a reflexive process, sort of like swallowing. We have a little bit of control over it, and then it becomes reflexive. So there's a part of it that's controlled and a part of it which is highly coordinated. So when I say reflex, I'm really saying more of a highly coordinated series of events that have to happen, over which we don't have total control. Okay, so the bladder is going to start squeezing, and now the urine is going to travel through the urethra. Again, this is the mucous membrane. It's lined by a mucus cells, and I've already described the two sphincters that are along the way. So there was the internal sphincter, I'll show you the pictures in a moment, and the external sphincter, which is really our toilet training muscle. That's the one that we need to get control of as a kid, and the one over which we hopefully have control for a long time. Distinguishing between the male and the female urethra. The female urethra only has one function, and that is for the passage of urine. It is relatively short, 3 to 5 centimeters, 1 to 2 inches basically long. So this makes women more prone to urinary tract infections. Looking at it, here's the trigone, right? Opening for the ureter, urethra. So there's that trigone, that triangle. It's kind of it's an imaginary structure, but it is truly a 3-point structure within the bladder. In this area, right, this would be the detrusor muscle lining the bladder, and this would be the internal sphincter, smooth muscle, involuntary, giving the urge to go as the bladder fills. Relatively short urethra. This muscle layer is the urogenital diaphragm, a part of which is wrapped around the urethra, and that is the external sphincter. And then the urethra exiting at the orifice, basically between the labia minor. This is different from the male urethra, which is dual purpose with reproductive and urinary, passage of urine and semen, and as such is divided up into 3 parts. We've seen this as well. The prostatic urethra is a portion of the urethra that goes right through the center of the walnut-shaped urethra. Right through the walnut-shaped prostate. Then there's a very short part of the male urethra called the membranous urethra. Very short. This is the region that basically goes through that urogenital diaphragm area. And then the longest part is referred to as the spongy urethra. Some books will call it the penile urethra. It's called spongy because it's passing and protected by a cylinder of tissue called the corpus spongiosum. This is a partially erectile tissue in addition to the corpus cavernosa. And so the urethra is surrounded and protected by the corpus spongiosum. So the three parts, again, there's the trigone. 1, 2, 3 parts. There's our little triangle. In here, what would be in that muscle in that area? Internal sphincter, the prostate itself, urogenital diaphragm. The muscle right here would be the external sphincter. And then 3 parts of the urethra, put it in yellow, I guess, prostatic urethra, membranous urethra in the very center, and then spongy or penile urethra. So most guys over 50 start experiencing symptoms or signs of an enlarged prostate. So what are some of those signs, or what are some of those symptoms, I should say, that the prostate is enlarging? What kind of complaints do you hear about from older men? Say it again? Yeah, so they can't pee, there's an irregular flow. So you can appreciate if the prostate's enlarging and it's squeezing on the urethra, then flow would be interrupted. What other complaint does Uncle Joe have? Gotta go, and get there, nothing happens. As the prostate's enlarging, it's pushing sometimes on the internal sphincter. That's giving you the urge, like I gotta go, my bladder's full. But it's pushing from the wrong end. The bladder's not really full. So you have this illusion that I gotta go, but they run there and nothing happens. And it can also push down on the external sphincter and damage that voluntary control. And there's also, we'll talk about it next time, but what's merging right in here into the urethra? The ejaculatory duct. The ejaculatory duct is merging in through the prostate at the urethra, so there can be issues with sexual performance as well with an enlarged prostate. So those are all the complaints of Uncle Joe.
At what point would they remove it?
I don't know the answer to that, to be honest. Yeah, I guess when the symptoms are so great that, there's some problems there. Or it's becoming cancerous if they can do that. Now, what I've got left are about 10 minutes to share with you pretty much a highlight of a couple things and then a couple of new ideas. We're going to be skipping over and putting X's through a number of these slides, so don't worry, we're not going to get through all of this. So I'm going to skip over some gory detail in here. So we talked about urine production. We've mentioned how the blood is filtered, goes in through the renal artery, down to the afferent arteriole, into the glomerulus, and out the efferent arteriole. There's filtration that occurs in the glomerulus. Do you agree? That's where filtration occurs. And there, we're going to be getting water and glucose and nutrients and ions and electrolytes, and all of that stuff is going to be pushed through those little fenestrations of the glomerulus. That's happening as what we call filtration. That's really the first process of the kidney, is filtration. Then, skip. Big old X. Nothing on there. Big old X. Nothing on this picture. Then, we get to reabsorption. Now, when you hear the reabsorption, what part of the nephron needs to be going ding, 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 ding? Reabsorption was the primary job of the proximal convoluted tubule. So when you hear the word reabsorption, think proximal convoluted tubule. And what was happening here? Reabsorbing, right? Collecting the water back, collecting all the useful nutrients back. The water's coming back in through osmosis. We're collecting all the proteins, all the glucose, electrolytes. We're getting all this stuff back into the body. It's being reabsorbed, remember, into those peritubular capillaries. Then, it's going to go down the loop of Henle. And I just told you that we're concentrating and modifying the urine. No specifics there. We're just kind of monkeying around with the content of the urine as it goes down the loop of Henle. And this slide, big old X. We'll wait for that next semester. And then we get back up to the distal convoluted tubule, and that's where this process of secretion happens. And secretion was what? The opposite of reabsorption, which means what are we doing? We're taking stuff out of the blood and putting them into what will become the urine. Remember, reabsorption was the other way around, right? We're taking stuff out of the filtrate and putting it back into the blood. So secretion happening in the distal convoluted tubule, and the molecule I told you to think about for secretion was acid, H+. So here's a simplified picture, very simplified picture, but I think it's a really good one to look at. So we've got blood coming in. We'll call this, I guess, the renal artery eventually. And then here's our afferent arteriole. Comes into a simplified cartoon of a glomerulus in the renal corpuscle, exits out the efferent arteriole, and then would go along those other capillaries, right? Would become the peritubular capillaries. That's the blood flow. Now, what happens at the glomerulus? What process happens at the glomerulus? Filtration. Right, so we see the arrow, and the arrow is telling us that things are leaving out of the blood and they're coming into the tubes, right? This wrench-like structure is the tubes, and rather than having the tubes all wound up, they just kind of made the tubes straight, kind of simplified the whole tube nephron structure. So after we've done filtration at the glomerulus, then we're going to do the next process, reabsorption. Reabsorption happened where again? Primarily in the proximal convoluted tubule. And what does it represent as far as arrows? Things being taken from the tubule and put back into the blood, specifically into the peritubular capillaries. Then, the next process that happens is secretion. That was the opposite of reabsorption. The arrow's going the other direction. We're taking stuff out of the blood and putting it directly into what will become the urine. And where did secretion happen? Distal convoluted tubule. Now the fourth process is not listed here, and I wish it was. Urine is going to leave through excretion, right? Exiting, excretion. So the four processes of the kidney: filtration at the glomerulus, reabsorption primarily by the proximal tubules, secretion primarily by the distal tubules, and release from the body, excretion. Right? So filtration, reabsorption, secretion, excretion. I've already told you about ADH. Where did ADH work? Where did I talk about ADH? The distal tubules, and I mentioned in passing that also if you're really, really dehydrated, urine or filtrate that's flowing through the collecting ducts can also have the water sucked out of it. So that means that ADH works on both the distal tubules and the collecting ducts, sucking more water into or returning it back to your body. That's going to make your urine more concentrated. And again, this is all under hormonal control. We're going to cross this one out. We'll talk about these hormones next semester, so no worry about renin. We're also not going to worry about aldosterone this semester, so we'll cross off aldosterone. And we're not going to talk about them, so we're not going to show you the picture. There's another hormone, though, that I want to introduce to you. ANH, atrial natriuretic hormone. This is a really cool hormone. Really important, too. Atrial, we haven't heard that word in a while. The heart. Right? The heart is releasing hormones. This is cool. So the heart itself is actually an endocrine organ because it does release hormones. Natriuretic, natrium is the Latin word for sodium, Na. Hormone. So here's the story with this hormone. It's released by the atria. Remember, the atria are the receiving chambers of the blood coming into your heart. If too much blood's coming into the atria, basically too much blood pressure, if there's too much blood rushing into the atria gets stretched. And as the atria gets stretched, the cells there will release this hormone, atrial natriuretic hormone. Now, what do you think this hormone is going to do? You've got too much blood pressure. This hormone is going to travel from the heart through the bloodstream and go to the kidneys and tell the kidneys to do what? Let it flow. Because the more fluid you get off your body, it's going to directly affect your blood pressure, right? So if you're urinating more, your blood pressure is going to go down. So this is a naturally occurring hormone. It's part of the way that your body regulates your fluid levels and your blood pressure. ANH. So why is it called natriuretic? Is because the way it works is it causes a decrease in sodium reabsorption. Now I need you to think about that for a second. This may take a mental cartwheel. If you're decreasing sodium reabsorption, you're not allowing as much sodium to be taken back up by the body. That means that the sodium is staying where? In your urine. And we learned in lab 2 that solutes suck. So the more sodium that stays in your urine, the more water that will follow that out of the body. Right? The sodium, the solute will suck the water and keep more water in your urine and make your outflow greater. So this hormone, when your blood pressure is high, your heart sends out ANH, your kidneys say, let it go. And it works specifically by interfering with sodium reabsorption. So this is just one of the ways that our body is able to regulate and maintain this. That was interesting. Well, there's only 2 more slides. Computer went to sleep. Okay. I've just got 2 more slides to share with you, and then I'll reconnect here. That is so bizarre. Has that ever happened before? Not? It's weird. There was a little power surge or something. Okay, so that's ANH. What's the next slide saying? Does it say caffeine and alcohol? Alcohol and caffeine, okay. I'm going to get this on video, though. So alcohol and caffeine are both also diuretics, which means they're going to cause you to urinate more. And they do so by different mechanisms, but they are both diuretics. Come on. So you drink enough Coke or caffeine, right? You're going to urinate more. Drink alcohol, you're going to urinate more. But they both cause urination, but they do so by different mechanisms. This is crazy. Okay, so just really quick. So alcohol and caffeine are both diuretics. They're both going to cause you to urinate. So you drink Diet Coke or Coke, you're going to urinate. Drink alcohol, you're going to urinate. But they do things by different ways. This is what alcohol does. It inhibits ADH. Okay, so alcohol inhibits ADH. Now, what did ADH tell your body to do? Hold on to the fluid. Alcohol inhibits ADH. Therefore, let it flow, let it flow. This is why it's never a good idea to be drinking alcohol on a hot day where you don't have access to other fluids, because the alcohol is causing you to urinate, you're already dehydrated from the weather and from the heat, and that can be a disaster, especially if you're in Florida on the Gulf of Mexico in a boat surrounded by salt water. And so we hear about these, these devastating things all the time where people are drinking on the boat, they don't have fresh water, and they basically dehydrate themselves. So that's one thing to think about. Now, caffeine also works as a diuretic, but it works so differently. It actually inhibits sodium reabsorption. It does the same thing that ANH did. So ANH also inhibited sodium reabsorption, so caffeine and ANH have the same mechanism on the kidney. Lastly, very quickly, the kidneys are working really, really hard to maintain your blood pH around 7.4. We won't go into the mechanism of it, but we'll talk more about this a lot next semester, but keeping your blood pH at 7.4 is a very important homeostatic measurement, and the kidneys are huge in maintaining that pH balance. And then finally, like every other system as we end up, what happens as it gets older? Well, it falls apart like everything else, right? So the kidneys start to reduce their size. With that reduction in size comes less blood flow. With less blood flow, there's less, filtering. There's a decrease in the number of nephrons, so the number just kind of, slowly starts dropping throughout our lifetime. So therefore, we no longer have the tight regulation of reabsorption and secretion. So we're not filtering our blood quite as effectively, and our hormone levels at ADH become a little bit less regulated. Well, as I've already said to you, if our kidneys are helping to maintain our blood pressure, aren't they? We've talked about that a little bit. So if your kidneys aren't as effective in maintaining their fluid levels and hormone levels, then you might expect an inability to control blood volume and blood pressure. So as we get older, ability to control blood pressure is decreased in part because of the kidneys' decrease in function. The bladder will get smaller in size, which means more frequent visits to the restroom. And finally, hopefully no time soon, we might lose control over our external sphincters, right? So that all depends. Okay, so we will be finishing up, that's the last time. We'll talk about the urinary system. Next time, I will be recording this from the morning lecture, and that means I'm not going to see you guys on Thursday. Tears, right? But I will see you in a week, right, at the final. So I'm not saying goodbye. I'm just saying good riddance for the week. And I will record the reproductive lab. Has everyone found the YouTube videos in the past? I'll send out a little video link to doing that, but I'll record the morning lecture. I'll post that afternoon lecture. By noon, you'll be able to listen to the reproductive talk, and that'll be the last content for the exam. We're done with the vocab. And then I will be seeing you guys next week. The final exam will be next Tuesday at 4:15. Regular class time, 1 week from today. Make sure you get your...
That's the last class we have.
Yeah, the test will be the last class. This was the last lecture. Thursday was officially the last lecture. Then next Tuesday, the final exam. Don't forget, you've got your mastering assignments. Go ahead and do your urinary one, your respiratory one. Save the reproductive one for after Thursday, and you have all your points. So if you're not sure about what your grade is or how that works, let me know. But I'll talk to you about your grade. Okay, off we go.